The Diagnostic Odyssey Continuum, Translations in Newborn Screening. Hi, I'm Lynn Bush, and I welcome everyone. I thank NBS-TRN, Amy, the whole crew for 15 years, hard to believe, of NBS-TRN and all the funders, and the 60th anniversary is quite an honor of newborn screening, for which I've been for more than 40 years part of, so it really is quite meaningful to me, and thank you. I have no conflicts of interest to report. Everything is my own, not any affiliation. I'm at Boston Children's and Harvard Medical School with a bunch of committee work and such, many of them very much related to newborn screening and the Translational Research Network. I'm a combination, much like NBS-TRN is, of very multi-professional group as well as caregivers. And this is just a little element of my reach, because I actually have training in clinical psychology and developmental psychology, as well as neuroscience and bioethics with multiple degrees. I have a lot of affiliations. And along with the affiliations, it really ranges from fetology and the neonatal space through pediatrics and into transitions, as we see as many of the children who we serve in the NBS community. Children are surviving, fortunately, but we also have to do better caring for them as they transition to adulthood. Some of my mentors along the way that really influenced where I am today and how I view the rest of the talk. Dr. Isabelle Rapin was a child neurologist, and she actually, during my internship, was at Einstein, and I remained in a mentorship relationship with her until she passed away, maybe it was 10 years ago. And she actually coined the term, or at least kept on referencing to autism as a spectrum, which has influenced even the title of my talk today. She also delineated and elucidated that Tay-Sachs had a late onset phase, and it was really quite instructive. And at Einstein with her was Dr. Oliver Sacks, who was definitely known for his storytelling and got me very much interested in narratives and the stories that patients tell, that caregivers tell, that professionals tell. We all have something to learn from each other. And I think NBS-TRN does a great job of managing that dance and choreographing it into everything we did. And from the neonatal end, I was at Columbia for probably 4 decades. And Dr. John Driscoll used to be head of neonatology, then head of pediatrics. And then I had the privilege for well over a decade sitting with him on the ethics committee at Children's Hospital. And Ron Walkner, who is part of NBS-TRN, was an influence because everything that we did related to the prenatal space as well as pediatrics and how we look at everything that we do today. So what's a Diagnostic Odyssey Continuum? I must say I should have published it probably 4 decades ago, but it's something that I informally used, likely coined, but somebody maybe out there who preceded me, since the mid-'80s. And it was influenced by Dr. Rapin, who, as I said, really looked at everything that we did as falling in a continuum. And I've always incorporated that. Historically, I used it in the prenatal-neonatal conditions, pediatric rare genetic diseases, IEMs, and inherited metabolic diseases, and developmental disorders. And it was particularly applicable that I used that term for a paper that I'm going to discuss and how I look at newborn screening, because it's a journey that many families experience in their attempt to navigate and understand and live through the uncertainties of the spectrum and the evolving course, ranging from the presumptive diagnosis. We won't even talk about the beginning screen, the confirmatory diagnosis that many consider a label, and all the uncertainties in both the prognosis and the management. And fortunately, we're finally having at our disposal some more possibilities for management, which is so exciting. And I look forward to NBS-TRN in the next phase as we end this 15-year mark, and hopefully we have lots more to do dealing with some of the new treatments, because even with a molecular label as we're incorporating into NBS, it's often not the end of the Diagnostic Odyssey story. So again, looking at everything at a complex continuum, I look at hope and the concept of from diagnostic optimism and the ways that people relay information and hear the information can be misestimated, can be misexpected, and it can be misconceived. And this is also the same as their prognosis. It is a continuum as we try to understand and learn from each other. Because after all, the counseling is, newborn screening isn't a test, it's a whole process, it's a system. And these continuums keep on going on to hopefully there'll be some therapies. And with those therapies are the more standard concepts of therapeutic misconception. But I like to stress all the other parts of the continuum because those are much more likely to occur. I was also very much influenced, and it impacts me for the newborn screening world considerably, by a mentor, Al Solnit, who I worked with during this phase of when they were conceiving concepts of the best interests of the child. And Solnit, Goldstein, and Freud had said, as so long as the child is a part of a viable family, his own interests, and I use sick as his or her own interests, are merged with those of the other members of the family. And I think that that's really important for shared decision making. I think that Solnit and Green, when they were talking about some of the PKU anxiety syndromes and others, they really were focusing on what needed to be done for communication and education and counseling. And the impact isn't quite as dire as some people interpreted. Knowing Dr. Solnit, he often felt that it was misinterpreted to mean don't do newborn screening. That is not what they were saying, but always identify that there'll be some people more vulnerable than others with different variables and tolerances, and we need to be respectful. I always think of word clouds, but I don't know how to do a word cloud. So instead, these aren't necessarily what other people think, but some concepts that I look at for newborn screening when we think of what needs to be done, what needed to be done all along in the past 60 years. Oftentimes weren't done. And I think this is such an exciting time because we're finally starting to look and recognize through research some of these questions more than just a handful of qualitative studies that's looking at small populations, but we're really, really delving into it, and it's an exciting time to be in. So how do we navigate the very complex landscape of newborn screening? We're really looking at a lot of benefits and a lot of burdens at the crossroads, and we can carve a path. It's going to take work, but we can actively carve together as long as we stay unified and stay very diverse in our engagement. So how do we expand the ethical landscape? Well, that's what we're here to do today. One of the things that I do on the other end in my life of expanding the landscape is looking at therapies and therapies for ultra rare diseases. And with Tim Yu, I'm a collaborator to the U Lab for ASOs and antisense oligonucleotides, and also work with others in terms of collaborations for research for many of the conditions that we're looking at currently, but also looking at in the future to be integrated with varying levels of genomics as we're able to elucidate some of the disorders. We fortunately have a grant, and we were funded by the NHGRI, and I'm co-PI with Tim and with Ingrid Holm, looking at ethical guidance so that we can help navigate the field going forward. My work contributes towards the progress of newborn screening and research and NBS-TRN in many ways. So one of the things that I'll be talking about a lot today is the idea of, with the continuums, of knowing it has to be longitudinal. And that is something that NBS-TRN has really looking at closely and making available to researchers because it is a process. Also, the NBS-CR is something that I'll be referring in an article that I co-wrote with Laura Koehly and colleagues at the NIH, referencing newborn screening related conditions. And that was largely, I started with that, and then all of a sudden it was up on the board, not my own doing, but certainly the NBS-TRN crew, to know how vital it is. So I have many opportunities, just a few choices because we look at rare diseases, is I'm on the co-chair of the policy and advocacy work group for the Centers of Excellence at Norwich for rare disease. I worked with international population genetic screening with colleagues at Harvard. And I went back and all of a sudden saw something that I presented at Boston Children's Hospital at the very beginning of this third phase of NBS-TRN being funded. And it was right after CRAB-A, many will remember on the call, for all the complexities that were evolving from New York State, and Michelle Kagana and Joe Orsini and Melissa Wasserstein and crew were looking at for so many of the complexities that were raised when you have such a rare condition with many late onsets and whether it becomes a condition on the rusp. So a glimpse into the ethical components. I'm co-chairing with Dr. Olaf Bodemer a special issue in International Journal of Neonatal Screening on ethical and psychosocial aspects of genomics in the neonatal period. And what I tried to do is I invited a handful of people and also kept it open for folks who wanted to contribute. So it was up there. We started pre-pandemic, and it's actually just closing with a couple of late, but I did it that way so that anyone was welcome to contribute an article, and then of course going through their regular peer review process so that we knew that we weren't excluding anyone. Because I think part of NBS-TRN's work, as well as the work of all of us on this call, is that we need to collaborate. We need to open it up because who's at the table? And that, so the very first thing I did since Dr. Harvey Levy asked me to co-chair and be co-editor of the special issue is I asked Dr. Levy and Dr. Rod Howell, who are just two stars from the beginning of NBS-TRN and the world of newborn screening, to write commentaries about telling stories that perhaps younger people never heard of that I thought were important. They're in the issue, and I won't go into it now, but please go back because it goes back to PKU and Sheila, stories that they shared that are precious, and I don't want them lost. Right now, I'll focus on research that I did that is completely related to NBS-TRN, and it's funded by NIH, NHGRI, through an intramural grant that Laura Koehly has went through their IRB, and it's based on a huge study, and this is just one segment. And I'd like to formally acknowledge at the NIH, Peter McGuire, Cindy Tift, Chuck Vendetti for referring the participants in the study, and all the participants and families for sharing their experiences as part of the study. So we looked at narratives from retrospective in-depth interviews, and it was a relatively large study of family caregivers with what I consider the newborn screening related conditions, albeit NBS-CR from NBS-TRN largely, as well as some that we anticipate will be in there hopefully within the next year or so. And we looked at it to provide some rich empirical data about the journey and the challenges that they experience, because they describe landscapes that are replete with unknowns, uncertainties. And in this current paper, they have a study of going, I've been working with the qualitative interviewing component for about 5 years now. And within that, we're looking for this current paper of just the lived experiences of 169 family caregivers that were specific to the newborn screening related conditions versus perhaps other IEMs and undiagnosed conditions, to see some lessons learned that we may extrapolate from looking at genomic technologies in population-based newborn screening. So when we look at it, we're looking at it as we're identifying themes that are characterizing the family's diagnostic odysseys continuum, which we recognize in interpreting that they fell into two domains: the medical management with the child diagnosed with such a condition and the psychosocial implications. And there's much intertwining. We just try to separate it for the purposes of the analysis. We're looking at the multifaceted challenges that they've had, that they're expressing with their rare diseases, and they're describing their experiences consistently using the word odyssey as they move into a caregiving role filled with uncertainty. And again, these are all newborn screening related conditions within this smaller yet significantly large group of 177 interviews. Many of the caregivers expressed that in addition to the rarity of the conditions, the phenotypic variability really compounded their challenges with uncertainty. They all almost consistently said that a medically named diagnosis didn't capture their lived experiences or the prognosis that they were facing for the child or the family, and that the rarity of the conditions and the phenotypic variation really shaped their diagnostic odyssey continuum. So it went from the screen to the presumptive diagnosis and the subsequent modifications, and it impacted them as patient advocates as they interfaced with the medical community. One even said within the first year, she had 96 medical appointments, oftentimes with different caregivers. And then how they approach treatment-related decisions, which are all things that we consider very seriously in NBS-TRN in trying to help researchers investigate some of these concerns. So in the medical management, the largest component was there's still so much that's unknown. And what they were saying was that from the diagnosis, from the unknown odyssey, from the screen to the diagnosis, even though it typically begins at birth with the heel stick, for most of the participants, the diagnostic odyssey continuum didn't end at the time of the first reported finding. And that didn't just mean the screen. It also meant that for these, they all went from a screen to a diagnosis. So it was from what they considered their diagnosis. So then they heard the whirlwind. And what the advice that we asked them to, send one tip that they can recommend to anyone is learn as much as you can. You have to become informed. You have to advocate. You have to do this because when your child has a rare disease, finding the right doctors are important. No one else knows the information. It was all of the uncertainties and their experience with the medical community was faced with a lot of people in the medical community that they felt had no idea. Either we're telling them it's really nothing when it was something, and they're going to offer some treatments that we'll get into in a moment that, albeit that these are not new to any of us, and they've pretty much been said over and over for the last 60 years, what they're telling us in these recent interviews is we haven't done a good enough job. And I'm hoping as we move NBS-TRN forward, that we can really move the dial, because we have so many wonderful researchers who we can all together move this so that when we have more and more genomics and more conditions, and I don't mean that it has to be a whole genome sequence, but we need to do better because we've in many ways failed. We're doing better now. We need to do a lot better from their stories. They're also, in regards to treatment, very confused. On the one hand, saying there isn't this treatment and that treatment as in with many conditions, but then they're also really stuck of how specific it is to their own family. And they need others to help them. They need navigators to help them figure out how to get to that treatment, or even to find out, is there a treatment? And these factors are helping them as they're navigating from making decisions that they're constantly needing to reevaluate. And that's part of their odyssey. They're trying to understand, going to a clear path to understand the prognosis, care, and treatment to prevent deterioration in their outcomes, even when they have a medically named diagnosis. They're looking at the treatment interventions still with hope, and hope that the new genomic technologies will really are just going to be around the corner, or at least, as one said, at least on the horizon. But while they're having the hope and the optimism and the expectations for the new discoveries, it's also taking a psychological toll on them, because they have their fears from the future, because there is such an unknown. And they also fear the acceptance of their child. So we look at the psychosocial domain, and throughout anything that referenced any concept of a psychological process, it was always accompanied by there's no clue to the outcome, and that the spectrum is so wide. Regardless of whether the condition is something that was treatable, or whether it was a very, very serious newborn screening related condition, maybe an MMA or a PA that already has very early transplantation, they felt it's still an ongoing battle rhythm. But yet there was always, for some, and certainly not all, but the meaning making that would accompany some of their heart-wrenching stories was that learning to appreciate what you have and not what you don't, because oftentimes when they were together with other caregivers of children with related diseases, or going to something, it might be at NORD, might be related to Genetic Alliance, and clicking on other caregivers, many would say it can always be worse. So there's the fear of the unknown, the fear of the unknown future. From these, the lessons that we learned for policy points was from the first set with medical management, they desperately are asking for educational resources for the healthcare providers, for the families, for the trainees, for the students. They feel that more needs to be known. They want empowerment programs for family caregivers. They want the training in patient-centered communication. This was something that over and over, they wanted people to listen and respectfully. They wanted to have access to multidisciplinary specialists. And with this, I add equitably, because we have to figure out both regionally as well as sociodemographically, and equitable has to reach everyone. We also, in domain 2 for the psychologic, they were asking over and over, not just for more respite, but most importantly, for continuous long-term counseling resources. Just like newborn screening is a process, and we've always hoped for and known it should have an NBS-TRN constantly, and I always think of Sue Berry with this and all of our meetings, there's long-term follow-up, but there needs to be long-term follow-up for counseling resources for the families as well. They want patient navigators along the way. Oftentimes this includes for language translations to do a better job, and they want more peer support programs, which in a way really surprised me to some extent, because I recognize how involved I am, and many of us on this call are, with so many peer support programs, but it's not reaching everyone, and it's not reaching a lot of the families. So we have to find out who's not hooked up and try to do a better job navigating them to places where they feel respected, they feel that they can belong. So we hope that these lessons can inform some of the policy. And again, these are not new lessons. We're just highlighting them because they crop up, and they cropped up in a group of people where we weren't asking them about the newborn screening system. What was really unique to this study is this was a study about rare diseases. And it was only because while I was involved in the study, started pulling out the basically NBS-CR conditions and looked at what they had to say. And it was also much of the analysis, the initial coding, were from people who knew nothing about newborn screening. So it was about as unbiased on the end, instead of asking questions about the newborn screening process. It was looked at retrospectively with a very different lens. So we need to provide all of these enhanced resources, making things accessible, vetting everything, building capabilities so that the families can advocate for their child. And we really need to do a better job with communication as providers and as researchers. They asked very much for, and overall was having an ease of access to the multidisciplinary specialists. And now that we do a lot, hopefully it won't get taken away now that COVID reimbursements are changing, but they wanted to help with the Diagnostic Odyssey. They wanted it for the acute and the chronic long-term management of their child's care. And they wanted to improve more realistic understanding and expectations of the conditions as the manifestations evolve. That's their Diagnostic Odyssey Continuum. They wanted help to shift to a new normal, because that shifting to a new normal constantly evolves. They need help with that. They're asking for help. They're asking for affordable and accessible provision of all these counseling resources. And they're trying to have, we want to help families to better support and cope with the Diagnostic Odyssey Continuum and the evolution of their child's condition. Because as the increasing number of rare conditions, disorders become newborn screening identifiable, we want to be able to help them more and more. We have to try for more mentoring services with peer supports and a lot more complex care management as they're transitioning, as many of the children from newborn screening transition into adult care and adolescent care. And with this, I look at it within the lens of the ethical lens, looking at non-maleficence, beneficence, autonomy, and justice, but it's for the family as well as for the child. In this special issue, that closes my portion of the article that again was with Dr. Laura Koehly and colleagues at the NHGRI, the Social Behavioral Research Network, and look at within this special issue, there was a rather compelling article that has certainly gotten some controversial attention, and something that I really feel passionate that we need to heed the advice of Dr. Levy and Dr. Howell for Robert Courier from both from Newborn Screening Translational Research Network, but also at UCSF and the California Public Health Newborn Screening Program, of really saying, we're not talking about let's not go forward, but we also don't want to throw out the baby with the bathwater. So what he's saying, what I passionately feel and believe, is we're not saying don't add conditions, but we have to simultaneously address all the problems that we've had in the past that weren't sufficiently addressed. Because as we're putting in new conditions, as we see with some of the lysosomal storage disorders, it is drinking from a broken water hose. And the people on the front line who are trying to deal with, trying to help in the clinical course, not just the public health side of it, they're swamped. So we need to do a better job. We need to make sure that there's social justice and fair access to all. I have in here just a couple of other articles calling attention. Many of them actually were from colleagues on NBS-TRN, and a few that I asked to approach it who weren't part of NBS-TRN, but with the lens of all that's familiar to us. And overall, from neurologists, neurogeneticists at Children's National, we have from certainly many, Erin Goldenberg, Beth Torini, Amy Gavaggio, many who are well known to the newborns, to the NBS-TRN community. We have Kristen Fischler and Luca Brunelli looking at, again, many access issues. And some colleagues of mine, Cynthia Morton, who many times has presented for at ACMG for both the Rod Howell Public Health Symposiums, and I've been chair of the Public Health Special Interest Group at ACMG for, we'll just say, over a decade, where we have usually 4 plenary-wise presentations at our forum. And Cynthia and many of you on the call have, and part of NBS-TRN, have very generously given your time educating others. So I want to really close, not fully close, but look at the continuum. And as we go forward with NBS-TRN and newborn screening, as we look at different conditions, I want to look at where we're putting our probes. I've always, when I showed Dr. Driscoll and Ron Wapner in the photographs early on, and Dr. Rapin, it's because we always looked at, and I always endorsed 40 years ago, you have to start introducing the concept of newborn screening in the pregnancy. And, you know, it's not so bad if, since most people don't even know when they become pregnant initially and it's not planned, maybe start sooner. We need to integrate the concept of the importance of NBS early on. We want to reduce some of the burdens across the developmental stages. And we certainly know that from prenatal to pediatrics and through all the stages in pediatrics, there's the significance of a phenotype that changes and evolves across the spectrum. I'd like to look at 2 last pieces of my involvement with NBS-TRN that I think were really important. And I chose this one, including LC research questions and newborn screening pilot studies that came out at the beginning of the first year of the 3rd rotation for the funding award. But it was really a process of working towards for the 5 years of that process. It takes a long time, I recognize. It takes a huge team who will oftentimes passionately disagree with each other, but yet we work for the purpose of really trying to help the children and the families. That's what we're here for. So I'll leave with the continuum of hope as we navigate the NBS-TRN ethical landscape and the practical landscape. I look at ethics very broadly, as many of you know, and I'm probably more liberal towards that end than many of you recognize, but I will leave it at that. So I thank you.